days, and especially a lifespan for a sickle cell red blood cell being 15 to 20 days. 3 months is a sufficient time for any medication to build up in the system, number one, and number two, to affect red blood cell, because 3 months is at least 3 half-lives or at least 3 lifetime for a sickle cell. So if it hasn't shown any response in 3 months, highly unlikely they will do anything. Because we just don't look at hemoglobins, as I mentioned before. At least that's what voxelotor has taught us. Is hemoglobin alone is not sufficient. It's the inflammatory cytokines which we check at every visit. It's the reticulocyte count and the hemoglobin concentrations, electrophoresis concentrations that we check. So it's a combination of many things. And if we don't see clinical response and a hematologic response, that's when we say, hey, it's time to quit or stop.
Okay, so I guess basically you think like for Oxbryta, for them to show pain crisis reduction, maybe 3 to 6 months should be enough in your view, right?
Absolutely.
Not a matter of duration of treatment.
Yeah, you are right. Yeah, absolutely. Hydroxyurea, for example, starts showing effect in terms of hemoglobin and minor pain reduction within a month of reaching a therapeutic drug level. Glutamine, L-glutamine, which is the Endari proprietary form, most of my patients who have taken Endari religiously for a month and a half, about 6 to 8 weeks, come back and say that it has started improving their endurance, sleep, and outcomes with respect to reduction in pain. Same thing with crizanlizumab. It's month-to-month infusion, so after 2 or 3 months, they start showing reduction in their pain crises. So I think it's all based in science. As I said, the lifespan of a red blood cell, and a healthy red blood cell, is 120 days. Lifespan of a red blood cell, which is a sickle cell red blood cell, is only 15 to 20 days. So after every 20 days, the red blood cell dies and new ones are made by the bone marrow. So if you have a drug that is supposed to have a mechanism increase oxygen or increase DPG or pyruvate kinase in the lifespan of an existing red blood cell, 1 or 2 or 3 life cycles is enough to show the efficacy or efficiency. Unfortunately, to my knowledge, I don't think GBT has put out, or I think Forma or Fulcrum has put out, or Agios has put out PK levels. So one thing that we do in our hemophilia bleeding disorder patients is, with every experimental therapeutic molecule, we do PK studies, which is pharmacokinetic studies. And I mean, that could be a suggestion to these companies to say, hey, with your trials, ongoing trials, why don't you just do a PK study and tell us how long does it take for a patient to take their oral medication to get to a steady state blood level for us to see, hey, it was in their system and at a steady state by, let's say, day 10, and it took about 30 days for it to be at steady state, for it to start showing effects.
Okay, cool. So let's talk about 601. I guess first, Dr. Jing, 601 obviously had an update at EHA. I guess I just want to get your general thoughts on the data so far, and how do you think that compares to Oxbryta?
I'll be very frank with you. The data that was presented in Europe for 601, and what I knew about 601 from ASH from last year, December, it seems like the mechanism it remains the same. I think the half-life has been extended, so it may have some benefits in having patients. Again, I am thinking of any of these molecules, whether it's 601 or the other GBT pipeline, which is the selectin inhibitor. Any of these medications, I am looking at the patient and how it's going to be rolled out in the community. If it reduces the number of pills, if it doesn't cause the side effects which voxelotor had caused, and if it can afford patients less frequent ingestion of the medicine by increasing half-life, then that would have been the 3 most welcome changes to Oxbytra versus 601. I haven't seen that yet. But having said that, the data isn't out. All of that data isn't out yet. So again, I remain hopeful because I believe in the mechanism of on this mechanism. But I still have to see more data to say anything or to comment anything on it.
Okay, so I guess they put out like data in 6 patients, right? So
yeah.
I know it's small numbers, but I guess just first look, if you look at, hemoglobin increase, and it's roughly doubles what Oxbytra showed in the HOPE trial. It's over 2 grams. I wonder if you look at that and then the other hemolysis markers. I mean, are you sort of convinced that it's a more potent drug versus Oxbytra? Or for you just have to see more patients' data?
So the 601 with the 6 patients was a single dose trial. It was an escalating dose trial, as I remember, if I remember correctly. So it was done to establish safety, right? And the safety was established. So we
can talk about safety later, but I want to get your thoughts on the initial efficacy data.
Yeah, so what I'm trying to tell you is the intention of the phase 1 trial was to establish safety of 601 as a molecule in humans. And that objective was met. That's the only thing that I took off from that poster present, or I think it was a poster or a oral presentation. Anything beyond that would be a stretch of imagination because, as you said, it's only 6 patients. And they were trying to get the dose right. So I think it was a 300 milligram cohort and a 400 and a 500 milligram cohort. So my only takeaway from that presentation was that, hey, we have this new molecule that works really well, that is safe to use in humans at a 400 milligram and a 500 milligram dose. Because a phase 1 by default is safety trial, so phase 2 and phase 3 data is going to tell us whether the efficacy of the medicine would be superior to Oxbytra or not, just because phase 1 is not meant to do that. Now the early signals of a higher hemoglobin rise is very, very encouraging. Let me leave it at that.
Okay. I guess on a number of hemolysis markers, I mean, they all show pretty, robust and consistent effects. They're seemingly more, better than Oxbytra. Can you just comment on how you view these markers? Is there any 1 or 2 biomarkers that are more relevant in your view? And more importantly, how should we think about the potential clinical implication here?
Right. So, again, you're trying to make me answer a question that I don't want to answer. But let me put it that way. See, again, phase 1 trial, clinically or scientifically, like what you saw with what happened with the vaccines, right? So, until the vaccines are FDA approved, or at least the phase 1 data were put out for COVID vaccines, we didn't say they were safe or not, right? So, it's a jump to say if this is going to be a game changer or not, unless we have phase 2 or phase 3 data done, or phase 2 or phase 3 trials even done and data available for us to review. But having said that, the most interesting thing that I saw that GBT did, along with what Fulcrum and Forma are also doing, is the ectocytometry, which is the red blood cell membrane stability. And the ectocytometry outcomes in these 6 patients, based on what they had said, was improved or robust. That tells me that irrespective of whether the hemoglobin goes up or down, the red blood cell membrane is becoming more robust, or the red cell hemolysis may happen less. And that is encouraging to me, because that's a very valid endpoint, which for the first time will have those results by the time phase 2 or phase 3 data comes out. So here's what I'll say. If the phase 2 data or phase 3 data, If the phase 3 data from 601 shows